Good morning and welcome to our monthly webcast. I am Samin Mehta, your moderator, and this is session number 87. We have another challenging CTO case that would be done via the retrograde approach. You can also watch us live on YouTube, and with these introductory words, let me take you to the cardiac catheterization laboratory where right up front, I would like to congratulate Dr. Sharma and Dr. Kini for the magnificent performance with the Department of Health New York State statistics, which has just been handed to me, but I am sure Dr. Sharma will provide you more details. Samin, good morning and congratulations. Not only is Mount Sinai and this magnificent system that you have created leading for the 18th consecutive year in volume, but also in the complexity and the safety of the outcomes.
Absolutely, and I take a great pride in this because clearly, people always say once your volume increases, your quality goes down. I said that's not true. As long as you pay attention to the minute details of your procedure, so that should not compromise no matter which level you have gone. And that's is a testimony to what is being achieved, done at Mount Sinai. So actually, yeah, you want to take one quick picture or we wait?
Yeah. I have been looking at these statistics and really some of the information here is mind-boggling. Just the how is it possible in the present environment to be maintaining such a combination of both surging volumes and yet maintaining the quality and such a low level of morbidity and mortality, considering the enormous proportion of the very complex cases?
Yeah, no, I mean clearly the R volume has gone down also.
But it's nothing compared to what is being seen in the rest of the report and nationally.
Yeah, absolutely. But I think it's still continue. I think what we have built, which we call kind of perfecting the art of PCI, although some complications will occur, and these are only the salient features which they published with the 30-day risk-adjusted mortality. But on other aspect, New York State gives the data to individual hospitals concerning their issues in terms of their stent thrombosis, CV rate, peri-procedure MIs, and vascular complications, and so. So just to say that if wanted to share this, as you said, the 18th year in a row report of our PCI just came about 10 days ago, and they give the data about 3 years behind and aggregate of 3 years and the individual year. So this is knowing that the really significance occurs when you start combining them for 3 years, and they put a 1 star if your risk adjusted mortality is state-wise lower than or higher than expected of the state, and a double star when the risk adjusted mortality is significantly lower than New York State. So double star is always better. They don't give 3 or 4, but just keep it 1 and 2 stars. So you can see here for a 3 year of 2011 to 2013, the latest report of the New York State puts us in very high commanding position in terms of the volume, and the 30-day risk-adjusted mortality significantly lower in the all cases as well as non-emergency cases. Emergency cases we didn't make it, rest of the institution data you can see. So overall very, very reassuring. And then individual volume of 2013 again 4522 versus 2500 with a second place Columbia Presbyterian St. Francis at third place with a 2289. Now also this is where what you said, the system has been created. This really speaks for, wait one second, the slides need to move there, they are not connected.
Okay, they are now.
Okay, yeah. The key is, as you see over the years, one or more than one of the interventionalists from Sinai has received double star. So last year we were 2, me and Kini, and then this year actually we are 3, B, Kini and Dangus. So just to speak for the system that we have created, and we saw that Pedro Moreno a few years ago, before that Match Cameron, so that we actually have almost the 5-6 people in the system who are double star, which is unprecedented. Nowhere ever in any hospital, 2 physicians, forget the 3, who got the double star in any of the PCI report in last 18 reports since they started coming. So very, very reassuring of the technique of the individual interventionalist, and more importantly of the system. Now, the volume wise, we continue to lead the state with myself and Dr. Kini, and then of course many other interventionalists shown here. At present there are 21 interventionalists who do more than 1,000 interventions per year in 3-year time period. Also they came now is the readmission, knowing that the readmission is one of the quality indicator, that readmission rate of all PCI in New York State, again Sinai being the 8.91 get the double star compared to the statewide average, that lower readmission rate. So all the way I would say that it was a great report card for from the New York State, just underscoring that yes, we are doing good things.
Samin, congratulations again. I picked up on a few points which were reviewed here. First of all, it's not only that Mount Sinai continues to do well, it is in the midst of such amazing competition. The sites and the other institutions which are comparing are considered also world class. Congratulations also to George Dangus. Yes. People know him as the face at TCT and ACC, but his interventional accomplishments have also been recognized, and I am delighted about it. Anu, what are your comments here? To you goes so much credit for shepherding this as the director of the cath lab, and possibly, if I am correct, this is year number 5 of the report since you've been the director?
Yeah. All I can say is the system, I think, started by Dr. Sharma, but more important, I think, just to continue in the same footsteps, whatever that has been created. But all I can tell you is one thing, how important it is to make sure there is a system process in place and protocol. You see, we have so many physicians who actually come visit. Every month we have 2 to 3 physicians who come from other hospitals, or more important from outside the country, who actually have traveled many other places, other parts, and they also tell the same thing, that one, the volume, it's being done, but everything because it's protocol driven. So it doesn't matter how many attendings are here, we have a protocol, and that protocol is built based on our experience how to do the case. So every case there is a system that this case has to be done this way, and that is taught to the fellows, is imbibed in them. So even if it is not me or Dr. Sharma doing the case, the fellows know that if this case is being done by them, this is the way the protocol is, and this is the way they would have handled it, and that is how other attendings also will do it. So that is within the lab that we have created. And other thing is preparation of the patient before. So we educate the nurse practitioners, so they know if a patient is coming, this is the way the system is, and if there is any disruption there, they will contact myself right now to make sure that this patient doesn't need cath, no cath, whatever those issues are. Every transfer will be the way that we have created a system, how transfers come in, either they go to the floor or directly to the lab if there is any issues, and post procedure, even whether they go to the ICU or whether they go to the telemetry floor, there is a protocol how these patients have to be followed. If there is anything post procedure issue, that they contact the lab here directly looking for us. So this system has been in place, but more important is to make sure the system works. So one person is here, which is myself right now, to make sure that the system works, and there cannot be ifs and buts, and the system cannot have any cracks, to make sure that this kind of high complexity cases are being done without any problem. But more important is that there is subsequent follow-up of this patient post procedure, and when they go home, they will also get a phone call through the system process that how they are doing within the next day as well as 30 days. That is why I can tell you that we see that results as a reflection.
You are absolutely correct. Congratulations to you for your leadership and to the entire army of the nurses and the technicians who also I think put in an excellent job, as well as your interventional fellows.
Beautiful. Now, while we can go through our quickly.
Thank you.
Thank you very much, Samir, and really, and our goal always has been that let the rest of the world do exactly what we are doing.
Look, they can replicate you in most other areas in the systems which Anu mentioned, but there is something unique which I think keeps you and stands you apart, and that has been your hard work and the discipline. You know, any systems you create, behind this there is all the blood and the sweat which you put in, and for that I offer you my sincere congratulations.
Yeah, I think two things always people, three things that you need. One is discipline in your life, two is dedication, and third is hard work. They all go hand in hand.
So what Samin, tell us what we have in store today. I do know it's going to be a difficult, challenging retrograde CTO.
All right. So we quickly go through, knowing that it could take some more time. These are our supporters, and we thank all of them, and our disclosure which are not changed in any way. And this is a very interesting 45-year-old male who actually presented few months ago with new onset lateral T wave changes. He ruled out for MI, and cardiac cath done revealed 3 vessel disease, culprit being 90% mid LAD, and total occlusion of the RCA with moderate lesion in the OM, and syntax score 17 and normal LV. So that time patient had a PCI of the LAD with the Promus Premier, started on medical therapy, aggressive medical therapy, and CAD risk factor modification, and then because of his continued symptoms, we did a stress MPI, which revealed moderate inferoposterior ischemia, and we knew that patient has a total RCA. He's on good medical therapy, and basically the angiogram will be shown by Anu now.
So this is what you see: left main, non-obstructive. So the proximal and the mid RCA may be less than 30%, and you see the stent in the mid to distal LAD, which is after the 3 septals. And actually the OM looks better now
The
compared
area,
to his previous angiogram.
the proximal segment before the stent, is that from this view, or is that just some tortuosity?
Yeah, I think
foreshortening I'm seeing?
there is some disease there,
Right,
but we
okay.
had called 30 to 50.
50, yeah, 30 to
Okay.
50, but we can take another picture of that. But stent looks good. OM actually looks less than even before.
Right.
This always happens acute episode when patient comes back. Vessels look a little less significant, lesions look less significant because there is no longer component of the spasm. And now in this particular case, the RCA, that's where the whole issue is.
The RCA is totally occluded almost at the ostium.
Right.
And that is the key. Remember, the idea is that which case you do a anti-retrograde to begin with.
To
This
me,
is the kind of case.
to me, that is the essential part of this case. Samin, go ahead, tell us.
Yeah, that basically where there is a ostial occlusion, there is not enough purchase for you to put a center cos or your device or your guide catheter, that you start with a retrograde approach. The blunt stump of the, let's say, the LED is closed at the ostium, you don't have which way to go. So those are the cases you do a retrograde as start. So this will be the case which will fall into the starting the retrograde first.
So if you see the second and the third septal actually is very close to the stent, but still it's not covered by the stent. But you see the actually the second septal probably has a direct connection.
Anu,
to the
let me point out something very critical. Now, when you were initially stenting the LAD, in your mind it was also there that you would be doing the right.
Yeah.
So did you carefully implant the stent at that location to preserve the access to the septals?
Yes,
Excellent.
I did. Yeah. That's why you see the third septal, which I could have covered with the stent, we have a millimeter gap. Of course, okay, you want to do that?
Yeah. So gap was particularly left for this purpose.
That if we have to open the RCA, that's good, that's good.
Yep.
That will be a retrograde approach.
And I think this is a very good picture.
And clearly there is no issue at all with the proximal part, proximal
LED.
to the stent. Yeah,
Absolutely.
exactly right.
Good. So,
So
tell us what you want to do,
goal will be that we have a Corsair and then we'll go with a fielder. We'll try to, let me go back to the previous picture. If you see here, if this is the second septal, and there is a straight connection of septal to septal. We'll try to get that septal.
So for all retrograde CTOs, your MVP is straight away Corsair.
That's it.
Yeah.
All right.
They do have the newer,
Yes.
the micro 14 catheter. They do say it's also equally good.
Is that your experience? Have you found it?
No, we have used micro 14 catheter in antegrade. It is good. It is it's more like it. I would say it's between Corsair and Fine Cross, where it looks like Fine Cross, but we can rotate it and try to get work like a Corsair.
Okay. So now with that, that's our plan today, with the retrograde recanalization, and then we talk about what we need to do, knowing that for last 2 our episodes we had taught everybody to do absorb the techniques point of view. Should we use the absorb in this particular case versus what? I think we'll see based on what we find that how we do a recanalization. So clearly it's appropriate by all the means because patient is ischemic on MPI as well as on medical therapy. So 2 points, while Anu is trying to do just trying to get a Corsair. As soon as we start getting Corsair in the septal, I'll stop. So what I wanted to talk today is, since we have presented a lot of data on the total occlusion in our earlier study, so I felt the real point we wanted to talk about, this major paper came out in the JACC as a lead article of the medical therapy versus PCI or cabbage, where you will see the data which are really against the medical, the PCI, even against medical therapy, not only cabbage. So I'll share with that and give you update on that point. And the second is we always present after the major meeting the key trials of the scientific session. So we'll talk about 3 European Society trials: the doctors, the North Stent, and the Prague 18. So clearly that this paper, which was the medical treatment and revascularization PCI or cabbage option in patients with type 2 diabetes and CAD, is a pooled analysis of 3 trials. Basically the Courage, diabetic patients of the Courage, which are about 786, Barry 2D to 2200 plus, and the Freedom, which are all diabetic 1900. So large number of patients, 5000 plus patients overall, and in which 32% had optimal medical therapy, 42% had a medical therapy and PCI. So OMT was always there, but question is alone or in combination of PCI or cabbage was in about 26% of cases. So basically what did it show? And that's the very important, that if you take the follow-up was anywhere between 4 to 6 years. So you take a death, MI, stroke, death, MI and stroke, clearly that cabbage comes superior in terms of the lower event rate of death, MI and stroke, death or MI, and of course slightly higher stroke rate. So this actually based on the angiographic criteria. Also we knew that there is always some comparative data of the PCI and cabbage. So what they actually have based on the LV dysfunction and based on the vessel disease 1, 2, 3 or the proximal LAD, what we learned basically is that cabbage versus PCI. So cabbage was superior, particularly for the 3 vessel disease, and you start having some trend in the 2 vessel, not in single vessel. Then proximal LAD or no proximal LAD benefit was identical with an event reduction of 29%. And lastly, that ejection fraction, whether low or high, you can see that overall there still remain a benefit of the cabbage or PCI, cabbage over PCI. Now the central column is the cabbage versus OMT, where you see that yes, some trend towards the cabbage, but you in those group, but PCI and OMT, you can see there is no clear benefit of PCI or OMT in these trials which were done in early stages of the bare metal stent, DES, and so forth. This actually puts everything together very nicely. Central illustration of the paper, that is the first one on the left side. On the top, cabbage plus OMT versus PCI versus OMT. You can see death, MI and stroke, cabbage all the way better against medical therapy or against PCI. But if you compare PCI with optimal medical therapy, there was no benefit. MI, again cabbage is superior to individual approach of the medical therapy alone or PCI, but clearly the PCI did not have any offer advantage over optimal medical therapy. So this actually you say, well, is it true? Then what are we doing here? Are we interventionalists? Is a bad thing if this is what we are doing to our patients, that all PCI patients who are appropriate could be randomized diabetic patients, that we are having a higher mortality and higher death rate. So to answer that question, there are actually a lot of papers have come in the literature on that. The first one was by the Bangalore in the CC in circulation cardiovascular intervention, that is, and the title was that can newer generation drug-eluting stent bridge the gap of the cabbage versus PCI, and answer to that is clearly look at the all cause mortality, go to the bottom, cobalt chromium versus cabbage, no difference in mortality, no difference in myocardial infarction. You go to stroke, rather you have actually, which we always knew, that the PCI had a lower stroke rate, and of course the repeat revascularization is higher with the PCI, that we know. So then there are the big New York State data which was published for the overall the multi-vessel disease with the EES comparing the cabbage, but from that subgroup the Bangalore also published this paper in circulation, that everlumus eluting stent versus coronary artery bypass surgery in patient with the diabetics and multi-vessel disease. And what did we find? The short-term outcome, look at the lower death rate with the EES compared to cabbage, and lower stroke rate, and of course so clearly the EES is superior in point of view, but you could go to the long term about 3 to 5 years, then you see identical death rate, but higher MI and higher revascularization and the lower stroke rate with the EES compared to cabbage. So what does it mean? It basically means the data which we have presented in this study, lead article in the JAC using the freedom, very true data and courage are ancient, does not have any implication of the present data, because that is what we don't use those stents which were bad. Texas, the cipher stents which used to have higher stent thrombosis, of course patients were having higher myocardial infarction and having a higher death rate. So this basically puts it together why cabbage should be even better than PCI in these cases. One most important in my opinion is the first which I have put it, that is in the non-culprit lesion, that if you what we do PCI, we take care of the culprit lesion only, but cabbage gives the protection for the non-culprit lesion by having a bypassing. So the acute event occurring from the non-culprit lesion, which occurs in almost half of the cases. We learned from the prospect trial, 24% event rate at 2 years. Half came from restenosis, half came from new event. So half of the event occurs in these patients occurs from the non-culprit lesion. So that is one protection. Second, of course, is the cardiovascular event as the function of the culprit, that our PTC and drug-eluting stents are associated with restenosis, stent thrombosis, vessel closure. So that is happened with the earlier generation stent. If you can eliminate that, you can take care of that culprit lesion related issues which give advantage to the cabbage. So clearly the newer generation will be different. And can you say that yes, we have the classical example of a trial called Tuxedo India done by Upendra Kaul, published in NEJM last year, comparing everlumus eluting stent with the paclitaxel, and basically look at this. All the event rates are almost half with the except the mortality with the Zions compared to Taxus. So clearly that whatever event rate has been in the past, stent thrombosis from 2% to 0.4%. Why patient will die from the PCI with the after the stent? Because they develop stent thrombosis. Now you are almost eliminating that stent thrombosis as shown by the newer study design, and we clearly have a non-insulin dependent the diabetes everlumus has the best outcome, event rate of 3% if you have insulin dependent and you take paclitaxel, which was 9%. So you have reduced the event by 33 to 50% by the newer stent. And therefore in the conclusion they do say in the editorial discussion that the results of our study, which is Tuxedo India, raise the question of whether the results of the freedom and the Berry 2D trial, or I would say the courage, which was part of this JAC print, would have been different if the trials had been performed with a newer generation drug-eluting stent, especially everlumus eluting stent. And the answer will be, at least we have some glimpse in the prospective randomized trial of the left main Excel, which will be presented next month in the TCT. So therefore, what has happened is that clearly what we used to have POBA, BMS, first generation DES, we used to have a gap between the cabbage and PCI. Now the difference is almost insignificant with the second generation DES. So clearly I would say that the central figure from, in my opinion, is not appropriate for the current generation DES. So newer DES PCI versus cabbage may have different outcome, similar death, lower stroke, slightly higher MI and higher TVR. So clearly I would say the PCI done correctly with the newer generation stent will have a different outcome. So quickly go to the second point of the trials. One is the doctor's trial, basically does optical coherence tomography, optimize results of stenting, and basically published in Circulation. Idea was they made a FFR as one of the important point, that what is the FFR number post PCI. If you can get it more than 0.9 was appropriate, or that is what desired. And of course the OCT was done in angiography group was done with the angiography, and OCT guided had OCT, and basically showed that by using OCT you do a more post stent optimization that result into a better FFR, 0.94 versus 0.92, or patients getting FFR of more than 0.9 was 77% in the angio guided group and 64% versus the 83% in the OCT guided group. And remember, I showed last month the data of the post PCI FFR with a bad outcome. So clearly you have a good outcome, better FFR should have a long term better outcome. So also many times the OCT makes you change your strategy, and the most important is by using the OCT you are able to get a better stent optimization and the MLA, very very important. So once you use OCT versus the after optimization, you improve the lumen further, and this is one of the important factor to get the best MLA in these patients and get FFR of 0.9. So stent expansion was much better in the OCT group. Same is the diameter stenosis by QCA was much lower in the OCT guided group, but unfortunate that with 6 months data which was presented, the MACE rate was identical between two groups, 1.6 versus 2.5. Again, it's a very short term data. You need to wait at least 1 to 2 years before having any curve separation. Now second issue, we always say that we are so much gung ho or worried about the DES, and so this is the largest trial with called NOR stent, which compared large number of patients undergoing PCI with the bare metal compared to DES, and followed the patients for 6 years. And basically what did they find? As you can see here, in about 9,000 patients, that there was no difference in death MI or individual point. Revascularization was the only difference. Revascularization was 16.5 with the DES and bare metal being 19.8. Also, the newer stent or all our drug-eluting stents have a lower stent thrombosis compared to bare metal, no difference in bleeding. So p value was just trend 0.05. So 0.8 versus 1.2. So anybody says that bare metal has a lower stent thrombosis is absolutely wrong. As you can see, this is the largest trial of the DES versus BMS, and probably will never be repeated again. An excellent presentation of the data in European society. Third is, we always talk about which one is better, is the prasugrel or ticagrelor patient with acute MI, and they actually, the Prague 18 answered that question in about 1100 patients, 1100 plus patients, that primary endpoint of 7-day death, MI, urgent revascularization, stroke or serious bleeding was identical, 4% in both the groups. And individual endpoints are here, death MI, stroke, definite stent thrombosis, maybe slightly 0.5 versus 0.9 in prasugrel, and then bleeding identical. So it seems to be both agents are identical in terms of their safety as well as their the efficacy endpoint. So this basically we learned. So I think this will be the largest of the study in a particularly acute coronary syndrome patient, where the both agents were compared in a randomized fashion in about 1200 patients and came with exactly the similar outcome. So with that note, we can come back to Dr. Kini now and tell us what is going on.
No, though we see that we think the septal there's a good connection, We tried to wire through 2 different septals. We still cannot get into the PDA, but
that was the third and the second.
Have taken some pictures or no? What do you mean?
it disappeared. No, we took some pictures.
No,
So
you
even
tried
though-
those, the third and the second septal, those were
Yeah,
the two
the
you
one we
tried.
thought that is directly connected is actually no connection.
You want
So
to
now
show
I
that?
read the third septal.
Okay.
The picture here.
Yeah, here. Oh no. So this is what we thought the second septal has connection. Now the third septal has the connection, but if you see there, it's not straight. Look at that.
Yeah.
It's not straight.
Okay. But you gave the injection through Corsair a little bit.
That was the second septal I did.
But show it.
Let me show.
Yeah. Good.
So this was, so I pulled back.
Not a direct connection, huh? Okay.
That was one. And now we are at the third septal. See, it just would not go further.
Right.
I don't know, maybe we
Would
could
it
have
make a
straight-
difference going through the superior of that, the side branch of the septal? Maybe that has a better connection, but maybe not.
You mean here?
Yeah.
He's in now the third septal.
Okay.
Third septal. Maybe I go up and see if I can get.
Samin, very comprehensive review of some extremely important topics. The story on the diabetes subset has gotten a whole lot attention and a little more tricky to interpret. What is your real take home message? What should one be doing?
Yeah, I can tell you after this paper, 3 of my referring cardiologists called.
Right.
He said this is the death knell of the PCI in diabetic. I said hold on, please. The key is this is absolutely different data. These are the stents which we don't use now. We all learned that those stents were bad to begin with. We can do after the studies. And with the current stents, current generation, we don't see those things. We don't see those patients dying, developing stent thrombosis. So just imagine that in the freedom trial there was 4% stent thrombosis in 5 years. Of the 4%, you know that 2% will die, 50% will die. Now, if that 4% has become 1%, your death rate from 2% has gone down to 0.5. So my personal message is that yes, appropriate cases in a complex with a high syntax score, patient with involving the proximal LAD, diabetic, first option should be given to the patient for the cabbage. But other patients, in my opinion, should be given a chance that with a newer stent, the chance will be that you may have a bed come back more, but you probably would not have a price of having a higher mortality or even higher myocardial infarction.
Well, in the meantime, Anu has clearly made progress there. Samin, going back to your argument which you mentioned, of course, clearly it makes sense and there is no issue with that. But could the surgeons also not say that 5 years later they have also improved their techniques?
Well, I can tell you the technique wise is that in this study from the cabbage 94% patient had a lima. So really, and remember the diabetic patients by generically don't get double vessel, the double arterial lima, although some cases still do. I mean IMAs, lima and rima, but majority of those cases still remain. So I think the technique, while there is a significant change in the techniques of the intervention, there has been some minor change in the technique of the bypass surgery. The biggest outcome determining in the cabbage patient is your use of lima, which in this registry
Has stayed the
this
same.
it was done in 94% of cases.
Right.
And I think the real benefit still remain, although the freedom included patient with a 2-vessel disease and there was some benefit there also. The real benefit in this combined study would be in the 3-vessel disease group.
Miracle 3.
So is
I'm at
that
the
your
crux.
practice at Mount Sinai today after the trial or even otherwise for the diabetic population?
No, diabetic population again, based on the stable angina,
want to inject
stable CAD
water on
analysis, that we, the recommendation,
Ready?
the guideline point of view, that we are still going with the 3 vessel disease,
Can you inject
particularly if there is a proximal and mid LAD disease is there. So those patients are getting a surgical consultation
Okay, with the heart team.
with the heart team. Yes.
So here let us put things in a very
Miracle
correct perspective. We reviewed in detail the superb progress you continue to make with the New York State Department of Health rankings. How is the surgical program? Do the surgeons have something similar which they rank also?
Yeah, surgeons also rank, and you will say that based on the maybe the syntax and now the freedom, that you will have a higher.
Don't mention
that,
anything else.
huh?
Don't
So
mention
how does
anything
Mount
else.
Sinai rank in that?
Yeah, we actually.
I think we should not.
Yeah, no, we are
discuss
okay.
that.
I mean,
Okay.
we are just all right. Mean we don't get a single or double star.
No, no. Look, I'll tell you because this is a very objective comparison. It's people have known Mount Sinai for excellence in the entire spectrum of cardiology and cardiac surgery.
And the valve surgery and so, but cabbage wise we are just in the middle.
Right.
And more importantly, that if somebody says, and actually I pointed out to the Dr. Fuster a few times that whether since the guideline for stable angina and diabetic patients based on the freedom and the syntax, has the cabbage number gone up in the United States? I cannot tell you for the USA.
Right.
I can guarantee tell you for the New York State, number continue to decline. While the PCI is significantly declining every year, although now plateaued for over 2 years, but declined by initially 9%, then 6%, then 4%. Now there is actually 1% increase in 2015. That the cabbage continue to decline 1% each year. So advantage of the decreased PCI did not translate into a increased cabbage volume. And
Perfect.
why? I would say it's the power of the medical therapy, because what is happening is, because of the whole concept the stable CAD can be managed on medical therapy, those patients are being managed on medical therapy and they are not coming to the cath lab.
Right. Right, which is I think eventually very good for the patient.
Yeah.
Samin, the Prague 18 trial, you think that has put the issue, I mean this is the
again?
benefit when two agents are compared head on.
Yeah. No, I think knowing that there are some data, maybe the STEMI patients, we felt the prasugrel might be better, and we also know in non-STEMI patients, ticagrelor may be better, or so. Just
Miracle 6.
for various reasons. So clearly that to me it has put into to the rest of this controversy which one is
Right.
better. I think these, we know both these agents are more effective than clopidogrel and should be selected and picked up in patients with acute coronary syndrome of whether it's a non-STEMI or STEMI.
Anu, in the
We are
meantime,
you saw one of the septal, we were able to get it.
Yes.
The thing
What
is-
did you do different besides a little more careful review of the angiograms?
No, we were more, I think we see here when we went back and reviewed the angiogram.
Right, right.
There are two issues. One of the septal which we thought is directly connected, actually if you see further down, can you see that?
Yes, we
As
can,
you're
very
reaching,
nicely.
it actually, it's very crooked, the septal as it reaches there. So went higher up and tried the parallel septal.
Yes.
Instead of going down, this crooked septal went through this straight septal which made through. But now what's happening, we are at the crux.
Crooked is a politically a very dangerous word to use these
Oh,
days.
okay. Curved septal then.
Okay. No. And what's the plan there now?
Now this is where we are.
Yes.
We are at the crux, but looks that
Still
it is
a
like
challenge-
a rock.
challenge there.
It's a challenge because this is where CTO starts.
Right.
So I started a real software which was a Miracle 3. It's not doing anything. Miracle 6 now. Now we have to start probably the
Do you
more
think
aggressive
you have to
ones.
slightly pull back the
which
No, we
did and
did.
will do
You're
it.
okay
We
there.
could.
Okay, yeah. In the meantime, I
Confidence
also
and
welcome the large contingent of fellows directed by Dr. Nick Cruz from the Philippines. I know they have been following our programs diligently, and Nick, thank you for your encouraging email communication. Samin, give me an update. There have been several questions not only during today's session, but before. What is the update on the reimbursement for OCT?
Yeah, the OCT the same. Just like I was for inpatient is the same DRG, so it's not a separate reimbursement. For the outpatient, 90% of the companies now, I mean insurance carriers, reimburse OCT also. Both, but they are all done. Remember, they are done only as an as the ambulatory procedure. But if you admit the patient, that is part of your DRG. The physician component remains different. So you are paid whether your patient is admitted or not. But from the hospital point of view, the patients who are admitted don't get separate reimbursement. Same thing like closure device, use of bivalvular and so on and so forth. But the patients who are discharged, there is a separate APC code, ambulatory procedure code for the OCT, and majority of the companies are paying for it now.
So clearly, the incentive there is for you to be doing more ambulatory cases, no?
That's absolutely correct. Yeah.
Samin, excellent review also of the trials presented at the ESC. I was there, and Pope Francis came and addressed the convention on the last day.
Inject
Wow.
the RCA.
You are also going to be doing live cases for TCT?
Yes. So we have it on Wednesday.
Do you know what would the case be showing?
Yeah, they wanted us to do a atherectomy. So we have a 1 hour transmission.
So that means you can do any case,
Yeah,
done at the hospital.
Right. They actually want, when we spoke Dr. Martin Leon, he wanted a one room, one case orbital, other one rotational atherectomy. So
Excellent.
we'll have a 2 side-by-side cases. And so, yes, 1 hour transmission on Wednesday.
Wonderful.
November 2nd.
That will provide objective comparison between
Two techniques.
yeah,
Yes.
between two, and very, I think that's an excellent topic, because so many people who still do not feel
They have a
that
major
comfortable
problem It's not making
are
a turn
moving
because
to
of this
orbital.
stupidity. See that?
Yep. So, and
Now-
yeah.
No, the Corsair is having trouble in going forward since this is the reason we need to try to get a septal that is probably connected.
More straight
Yeah,
rather than curvy.
here will be soon out of, it's not going further anymore.
So now question is, if you can advance the wire, then we can work it out with the KISS technique of the integrate.
Yeah, but
But
even
if the wire
I
has
have
to go.
I have to change to maybe more aggressive wire there.
No, in the, let's take a
Confianza?
one picture.
Confianza ready?
You want to take a one picture more?
Of where?
Just same from the LED to see how things are.
Okay. Go. Get me the Confianza. Let's proceed. Oh, actually, if
Almost
you think
there.
about it,
Almost there. Make it-
SSRC opened up a better. More.
Yeah,
No.
you did.
No.
Maybe you should try antigrade RCA. Can you inject antigrade RCA?
You have to take the ostium out, take
Yeah,
the cath out from the ostium a little
I
bit.
think you're just seeing the
No, this side
collaterals
was-
a
that's
little
okay.
better.
Yeah,
The native vessel stays the same.
You're out completely?
Yeah.
No, some die. Oh, no, you're there.
Good.
That's a 0.75.
Yeah, AL 0.75. Okay, no.
You want to get just Lima?
Okay,
good.
there.
Yeah.
Nothing.
Take it.
No change at all.
Nothing antigrade.
So the plan stays to continue with the.
Yeah, we'll
More
try to
efforts with
change
the
the wire now.
retrograde, yeah.
I think we're done with this wire. Now
Alright.
Corsair is not progressing anymore. Okay, give me the.
Confusion 9 we have. Make a curve.
Guys, you should not be making the curve.
No, get a new one. This is wrong.
Why are you making the curve? Make the curve.
Not make such a big curve and confine them. Just to say that you have to have very small curve. Can you show that? This is not the one. This is one.
Okay.
And it's the same thing that like Gaia comes out with a very small curve. There's not even 0.5 millimeter, like 0.2 millimeter. I mean,
You have a fine cross,
2
right?
millimeter,
If you have to go for anti-grade.
Yeah.
Ready?
You have the fine cross ready also?
Yeah.
Good.
Flush it, have it ready.
Fine cross with Gaia 3. One second. Yeah.
I think anti-grade we have to try because there may be a channel. Oof. Some LED injection.
And give me a retrograde injection again.
Mm.
Okay, take a cine. Now wire definitely had made more progress. Question is it going in the right direction? No. Let me study this a little better. I think leave this here. Let's try the integrate a little bit. Maybe we have to pull back the corsair a little bit.
No, cursor is okay. Now die. Now I think we are in the right place. Uh-oh. Pulling the corsair back.
Yeah. So I think the corsair has gone subintimal, which is okay. I think leave it there. Let's try the integrate. Bring the system.
Now die. We saw that.
No, some subintimal little part.
No, no, no. You want to try the Gaia here?
Not in this one. No, integrate. Pull back.
Wait.
Yeah, I think that rightly, as you see, no, it pulled back the corsair to really
Yes.
get to the lumen. Yeah. Okay, let's give it a little try. Integrate first. Leave this one here. Don't change anything. And question is, can this be sent
Can we
across?
get-
No.
For what? No, no, no. Now
there's
die.
no room.
Yeah. Let's take a cine.
Okay.
Go. I think oh, no. Okay. Just
yeah.
CTO.
Go. So until now there, what is not the right channel? And to stop the
What
engine
wire
for
we
a few
have?
minutes?
No, 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 no.
Gaia.
We are good. Pull back. Okay. Should have another mistake also we did. Okay, pull back. Are we there? No, 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 no.
Well, not with the
RCA.
guide, yeah, I know. Not with the guide.
Okay, there. I think we are in. Only question that this may not do anything.
Bring your fine cross little closer. So very challenging, you know, CTOs are always like that. What can you do? But that's what you want to try. If you pull the wire, where does it go?
Wire, you mean?
Take a picture.
No, we will not see anything.
Okay.
Retrograde. Take a LED picture.
No, but then you need a little more.
No, so at least will tell us.
Okay. Let's take a LED picture.
Let me a confianza.
12? Confianza 12.
Much more progress there. Anu, what is the antigrade wire there?
This is a Gaia.
It's a Gaia 3
that's
right
okay.
now.
Yeah, you haven't
want to
changed
go
it.
RFU?
Okay.
No, 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 no. Just give me a LED picture so we know are we in the rotating in the right place.
Samin, overall, what percentage of your volume now is CTOs?
The last time was about 8%. I mean, we are not recently, it seems to be a little more.
So
increasing
8% of the times none of you goes home.
We are outside somewhere.
Yeah, somewhere it makes the antigrade track and then loses direction. Somewhere in the, that's almost a corkscrew. RCA and bridging collaterals where.
I think we have to go back to retrograde.
So, Samin, no, you're not terribly convinced about any of those re-entry devices.
Yeah, we actually, you know what, also the data that
and the question I had was, would there be a role in this case?
No. First you need to create a track, go to the distal vessel, and that's where you need to use the device to get into the.
No, but that's okay. That's what you do cross boss to just go subintimal all the way.
So what was the comment you were
wire.
going to make, that you have not been terribly convinced about their
because
utilization?
Because just they create extensive antigrade or retrograde dissection,
right?
And we know that those are not good for long term. May look good short term, but not good for long term.
Some die now.
Huh?
Die.
Looks good.
No, I don't know. Even if we are a subintimal.
Till the mid portion, it looks to be in track.
Yeah. I think you need to go to the RO view.
No, more important, nothing moves. Okay.
So, is your success rate in the 90s when the first failed attempt comes back again?
Yeah, just about 92%. Because those cases are that you have decided, some which are really bad cases, we never bring them back anyway. But once you have brought them, there is a very good chance this will succeed again.
Right.
No, I think we
Now
went
wire
into
has
that.
gone. You want to take a cine? No.
Totally out, huh?
Yeah. It exit out from the mid.
Right, exactly in the mid. Yeah.
You see it now. Yeah. think this is the case you had to go over again, retrograde again, try.
Okay. Let's go with the start of the retrograde then.
Okay.
Pablo?
Anu, would any other different support rather than the
Guide?
yeah, or
No, that's what we were
instead
thinking.
of the Corsair, maybe, would you think?
Oh, the only other one is the micro 14.
Right. Would
Yeah.
would that make a
The
difference?
one reason I changed from retrograde to antigrade is because the Corsair is,
Not,
you know.
it's just stuck up there. Yeah.
It's just stuck there. If the Corsair moves little forward, then we can think of changing to the stiffer wire. But since that's why we thought maybe antigrade.
But do you want to change antigrade confluenger 12?
You know, when I saw one of
now?
the
No.
Antigrade.
retrograde pictures, one of my thoughts was to slightly withdraw the Corsair and
Yeah.
see if,
We did now. We are
Yeah.
back at the crux,
okay.
Now we have withdrawn it, yeah.
at the bifurcation.
Even you can withdraw a little more.
No, no, we are just at the angle. We cannot anymore.
But right now we are going through the posterolateral. What about going through the PDA? Although that's a far.
No, PDA no. Okay, let's give up the antigrade now. Or you want to go more aggressive wire antigrade? No.
Yeah. 12, no?
What are we?
12? Tell them throw this away, there is so much blood. Get a clean one. So we're trying the confluenger 12 antigrade before we go back to retrograde approach again. Throw this away.
So we started and we peaked out in the mid session around 8:40, and but we still have 15 institutions live,
Good, good.
and hopefully this
Very
is being educational in how do you continue to modify the technique as you struggle through a CTO.
Probably it didn't change angle. Okay, some die retrograde there.
In the meantime, I also have been handed this announcement, Samin, of your annual top 10 symposium on October 7th.
Yes, that Friday, it's for last 5 years we are done now, and it's a good because of we do a lot of interventional topic discussion, but top 10 cardiology topics. We started 5 years ago, and this time actually we have almost half and half faculty from outside. Usually you have Sinai faculty, but this time is half and half, and 3 are from the ACC,
Some die.
current president or ex-presidents, and so it really has
Same
taken off. You have to get the guide in a little better.
And where is the venue for this?
Venue is same at Sinai, our Eastern Auditorium.
Wonderful. So without giving away more, but what is the top advancement of 2016?
Yeah, no, but this is no. These are just the topics.
Different
that
topics,
We'll
yeah, the
select
10
the topic
topics.
of the latest controversy of the lipid,
Got
latest heart failure guidelines or hypertension, and so what is the best tool for imaging? So we select.
Is this course symposium mainly for the general physicians,
Yeah,
or
a general physician. Yeah,
got it,
international topics are just very limited.
right?
Yesterday.
Okay, so therefore we are quitting the back the antigrade.
Yeah, that was I think more done because of the frustrations from the retrograde, but the focus I think initially, as you mentioned, with the total occlusion straight out of the ostium, is the choice to attempt retrograde made all the sense.
The only
But this
question
is not something which I think is so unusual. One would often go with the strategy, then realize it doesn't work, try the antigrade, and now we are back to where we left.
Question is this. You think the micro-14, they said it's longer, no, micro-14 catheter?
How is the distal profile of that? About the same?
Of the micro-14?
Yeah, and the handling?
Yeah, it's more of a, modified fine cross, I would say.
Right.
Some dye in the, yeah. No, retrograde. That's good, go. Okay, now. Nothing? Ready? Huh? But what's the length? Length? Huh? Micro-14, right? Okay, now dye of the
Looks promising there.
retrograde dye. No, this one. Okay, now. Yeah.
Guide may be away, out.
No, this is the problem. No, guide is in.
Okay.
I think I need, get me the pilot now.
It made some progress further?
Yeah, it did.
Yeah,
This one
it
went
looks-
but now the stiff wire has to go up instead of going straight.
Yeah.
Curve into
You're
the
going to use the pilot for the antigrade,
No,
for the retrograde, no?
but,
Through the
curve.
corsair,
to
yeah,
make
okay.
the acute angle of the RCA,
Yes,
the stiff
yeah,
wire
yeah.
is not making it. See the last picture.
Yeah, this is the one.
So keeps going out now.
Yeah.
We have to go up. Let's see if this will make it. And then you have to go back. Keep this wire in the side.
Keep that wire in the position, bucket somewhere.
No, keep it here. We may need if this makes
This
it.
one back.
Okay, let's see. Maybe they're in the, on the
And we
different
probably-
channel.
Yeah.
What are they saying?
That maybe you need a same wire with a little better curve. You need a little stiffness right now.
Okay, now are we there? Probably not. Don't pull.
Looks to be making progress, but
Only question is if the corsair does not make a turn, even if we have got the wire there. Now die. Let's go Sine, wait. Okay, go. we go back to the same wire.
Yeah, I think that wire did go because this is just all
Floppy
this
flipping all over.
yeah. They called single jacket wire. There's no transition. So, but
Now die here. Where is that other wire?
you want to see the curve?
Yeah,
Make a
change
little-
it. Little,
yeah.
You just reshaping it or going
Yeah.
with
Reshaping the starter.
Mhm.
So stiff.
Good.
Okay.
Keep
Otherwise, you have to
pressing
go back with the fielder.
Hold it.
SS. Go back
Yeah.
with the fielder.
The filter alone will not make right now because there's still a long segment.
No, no,
And
no.
remember this
Just to
the
make
bridge.
the curve.
just to enter it at that
Okay, we got our. Oh. We created some subintimal.
Yeah, which is okay.
No, we're going somewhere else. Some dye in the LED again. Okay, ready? Let's take a scene before we really.
micro some
No.
Outside.
Samin, when you bring these patients back sometimes for a reattempt, what's the optimal period?
Has to be at least 8 weeks.
Yeah, 2 months. So whether it's CTO or any other dissection you have created,
Right.
so we know it takes 4 to 6 weeks to heal. So usually we make
Some
it
dye.
8 weeks, huh? You can decide to quit also.
Yeah, yeah.
And also the some cases you will say, well, you know what, I think there is not going to be a better success even comes second time and don't do it. So that may be okay. Now only question is, this is a young guy, he's still ischemic, he has some symptoms, that whether you give it a second try or now knowing that LED and those are okay, that should you go for elective cabbage. Although there is a moderate proximal LED disease, there is a OM, but those are non-significant. Or other could be that from hybrid point of view, maybe just put a REMA to RCA with a minimally invasive.
Right. Look,
Some dye.
would be a pity sending a patient for cabbage for the right, but hopefully we'll succeed today or at a second attempt.
Yeah. Wire is quite free. So it's basically probably not in the true lumen.
You meant distally, no?
Yeah, exactly. Although this is better, no. Yeah.
No. We started right from here again.
So today when I walked into our recording room in the back, I told our team of 3 very capable engineers here, I said, be ready for a long case.
Now it says.
Okay, I'll take a picture.
Clearly more promising. Something is no, not sure. What did you think, Anu?
Yeah, no.
Which we call in brief NG. No good.
Clearly no point exactly where the corsair is at this moment.
The question is, should we even draw corsair back further?
Yeah, either that, or I was thinking, do you think the smallest
No,
balloon
no,
will
I
sneak
think-
in there?
Huh?
The smallest balloon will sneak in there? Or a completely,
No. Yeah, I think we are going outside.
yeah,
That's how-
clearly exiting somewhere there in the,
See, this acute turn we are not able to make.
Yeah, I think from my point of view, knowing that we are given it a try, we are given all the techniques of the integrated retrograde, and then trying to combine with the integrate approach, and the patient has done okay. There is no complication. There is a little bit of dye extravasation here and there. Nothing wrong to stop now.
how much is, how are we doing with the dye and the radiation levels?
Yeah,
Very
radiation,
little.
like actually the radiation level is the 42 minutes, and the total contrast volume is what? 150 combined, both sides. What do you want to do?
Whatever you say. Get me, should we try antigrade or let us,
Yeah, what take this
Stiffer
wire
one.
into integrate?
but then we have to put something else here.
We can put any wire here. We have it.
Give me a Confianza 12, we never tried here.
For retrograde?
Yeah.
Okay. Confianza 12 for the retrograde. Yeah.
And then this one we can try antigrade and that's it. Done.
Okay.
No good.
Hold it. Take it off.
The patient has been wonderfully cooperative.
Yes. Actually, patient has been asking for.
Yeah.
We kept him on our PCI schedule in July and August, but because of the absorb, we bumped it up for this. So he was expecting this and eagerly, so we said we had to do it now. And it looked like it was a good case for the retrograde.
No, we knew it was, I mean, long segment CTO was,
Yeah, tough
knew
to
it was
start
hard.
with. Yeah,
Yeah.
yeah, yeah.
Question, do you want to pull back the corsair even more? So try to get a new lumen, pull back the wire, yeah, again, good. Now it's even trouble now, huh?
Yeah, it's like,
Yeah, because the idea was you needed to go look for a new lumen than what has been created before. But those old created lumens are not good.
are we in the right? Okay, ready?
Yeah.
So here is a very unusual question for you, Samin.
Yes.
How long did it take you to prepare the presentation you made today? Such a comprehensive, covering numerous trials, including the 3 recent ones from ESC.
Yeah, well, actually, you know what? I have one, my assistant, her
Yes.
name is Elena Ramos, and I keep making the slides almost every day. So I will make about anywhere from 10 to 50 slides per day. So any latest data comes, any articles I read early morning, and then of course Sunday I circulate, print it and give it to her. So this is compiling is the one which I did. So it has been a very busy 2 weeks for me, almost midnight. Even yesterday I went home at 11. So I worked to prepare the presentation because Sunday was quite busy. I thought will be only 3 cases. There were like 5 and very complex.
Well,
so
you also mentioned to me in last week you had many complications and had to come back long cases actually, stay back late. Yeah,
long cases. Yeah, long cases. The things were okay, no complication, but long cases. Yeah. And that led to that I worked on my presentation from 10:30 to 2 a.m.
Yeah,
so to put things together, and then again another 45 minutes this morning. But the presentations I cannot give exact time because these slides are made ongoing.
Periodically, so, as you keep going on.
When this JAC paper came, I already printed those. Now I put it together with the earlier papers which I have from circulation intervention by Bangalore and so. So then it's more of a putting together the synthesizing the data.
Are we in the right spot?
What do you think? Looking good? No.
Since we don't have an anti-grade also, okay, ready?
Okay.
Right?
Yeah.
Okay, let's see. At least lower part it made it in the right, I think, here.
Yeah. They're definitely looking a little more promising. I think both wires are meeting outside in the pericardium.
As long as they meet somewhere. No. That's yeah. Other one is definitely pericardial. This one we are not sure. No. Your wire anti-grade.
Let's take a picture.
Anti-grade
One more
definitely.
picture. Yeah. No, nothing go come with anti-grade. Retrograde picture. Take one more scene.
It's made this turn, but there at 9 o'clock it's again exiting, right? I think this is the case you need this CT scanner in the room.
Yeah, that is actually a lot of people, particularly in the Japan, they'll have the CT scan angio super added in the cath lab, so will give you guide you your direction. I think anti-grade is a little better position now.
No.
What do you think now? Want to give retrograde picture?
No. See, if the Corsair had come, if it had got in a little bit more inside.
Darker.
Why? Let's make sure they not get entangled and we cannot take the wires out.
Okay. What do you want?
Anti-grade out. No? I don't know where it is. Corsair does not go in anymore.
You want to take both the fine cross as well as the wire out from the anti-grade?
Retrograde die, so we know.
Okay.
Before going but not going.
Yeah.
Hmm? I think the antigrade should come closer to this wire, my retrograde wire. Can you? And retrograde is making it, except if since the courser is not extending, I cannot get this wire any closer. Hmm?
To me, I think give it a try with the integrate. You take the retrograde out completely.
Okay.
If not, we quit.
Okay.
Right? I mean, retrograde, do we know exactly it has gone?
We don't know, but it's reaching.
You have to pull the guide out a little bit, make it ostium.
In the ostium, you mean?
I mean, what we could do is, here create a subintimal space antegrately with our wire which we have, and then try to pierce with the retrograde wire. Truly carved.
No, but right now, why don't we get a balloon?
For retrograde or antegrade?
Take this out, we get a balloon, anchor this wire and try to get my corsair up.
Through the retrograde you're
Wherever
mentioning.
we are.
Yeah.
I mean, retrograde wire has to be anchored, corsair will come up. Normally we get into the guide.
Okay. Give us a
2.5 balloon.
2.5 12 compliant balloon. Give us a dark wire.
You want a dark?
Are they done in room 3? PCI.
Let's anchor it and see, right? Okay, you're out?
Yep.
Okay, let's go with a 2.5. Or what, 2.515? on. What did you give me? 12?
I hope that our viewers who've had the patience to follow this long case are benefiting from all the tips and the tricks. Two highly experienced interventional cardiologists pooling their intellect and their expertise in performing this extremely challenging case.
Give us a Lima guide, the side hose.
Either that or possibly just change. I bet you with the prolonged use the catheter tip has just softened and the shape.
Absolutely. Throw this away.
And from my recollection, Samin, this is our
can you go to
second
the-
longest case.
Okay, short. Yeah, short.
Yeah.
Short guide. No? Okay, ready?
It's not the one. No, 1 second. We are not ready.
Did you need a short guide? Lima. Okay. Okay, ready? It's not going flush. Okay.
Going to go now.
Go.
Yeah, take that.
Okay.
Okay.
Ready? Are you there? Yay. What you did you pull back?
Weigh the fine cross and the balloon. Good. Let's go with this wire.
You created a lot of anti-grade.
That's okay. Go.
No, no.
Channels, no?
Look at the anti-grade channel now.
Mm.
Get me the balloon.
You're subintimal. Okay. Okay, ready? Yeah, no, I think it's anti-grade. Okay, sir.
Go with another same.
Mm.
Get a new AL 0.75.
No, no, no.
That should be in.
Good. Go with this balloon and wire.
What wire is that?
Same wire you had. It was 12 or what was it?
No, it was
No, not
Gaia.
anything like Gaia.
It was a Gaia. Okay, forget this guide. Right?
Yeah, just pull the guide a little more and then balloon. Yep.
How will this balloon go? Whatever it is, the wires are meeting there.
Yeah. But we have to get guide a little better here. Advance the wire a little more.
But here,
You could look for a 1.512 also, balloon. Apex push. Go with Amflat's guide again, because this is no support.
I think the retrograde wire is in the lumen. Don't you think so?
Yeah.
But as it comes to the proximal RCA, it's not. Now they are. Let me see if I can get this wire going.
I know you want to continue staying, well, now it's too late to be.
Give us 5 minutes and then
No,
we'll
no,
make
no,
a
no,
decision.
no, no, not about that. I was meaning about the antegrade guiding catheter, right? Which
Oh.
because suddenly it has lost complete support. I mean
Yeah.
that AL1 was
Better.
rock solid.
Yeah.
If you want to change it, that's fine. I'm trying to see if I can get into the.
So now only question is maybe can you get retrogradely better into the Lima guide?
Right. And the Corsair has been firmly stuck in that position.
Yeah.
Yeah.
So it does not move.
Yeah.
The movement of this wire will be better if I were able to get the Corsair at least to mid RCA. Now it does not. We're stuck.
So Anu, as I was walking in to the room here, I saw a sign about interventional cardiology fellows. Was it for today?
No, the interviews, yeah.
Interviews. Okay.
No, no,
so
not for interventional cardiology
Just
fellows.
cardiology fellows.
Okay, I thought it was. So how many fellows does Mount Sinai have at the moment, clinical and interventional?
Yeah, so basically clinical are two programs. One is the investigator track, which is 6 per year, and then there are 4, which we call clinical track. So 10 this way, and then we have interventional fellows, there are 9, and then we have 2 hybrid, which are basically cath and PCI, 11, then we have 1 structural heart disease and 1 peripheral. So we have good team.
You have a massive team. There are 12 interventional cardiology fellows.
Fellows, yep, that's it.
That would make it one of the biggest programs for training in the country, no?
That's it, yep. Absolutely.
No, no. Can we go up? Would it anchor
And-
anything? Yeah.
Are you mandating that before they start the interventional that they go through the investigational track?
No, that is equal opportunity to both.
Right.
Whoever is more interested
Can come through.
will come through, yeah.
Okay.
Very good. No?
What do you want to do?
Dilate the balloon.
Okay.
Let's see if I can anchor this wire. I don't know where we are, but. Go.
Going up. All right. So let's see. Not touching your wire. Right? Is
Okay,
it or
down,
not?
down.
Now try to advance that balloon a little more. Now.
Only the wire has to advance. Balloon does not advance. Okay. Anchor now. Go.
No. No. I think you have to bring the guide a little more in.
Okay. Nothing.
We can get a 1 point apex push, that will go.
Down. No, 1.25 then.
No, 1.5. Apex push will go.
By itself, no. Okay.
Let's take this wire out. We'll do now.
I think if this anchor balloon does not work, we give up, okay?
Okay.
We are there, but still requires, I think.
All right, so we are going with the 1.5 apex push. To me, I think this is one of the very, although we can always go to 1.25, Spectrum Legend or 1.2
Mini track.
mini track.
Actually, 1.2 mini track comes in 6 millimeter also. They are what, 6, 8, 12? Glider?
No, not a glider. The glider is the different scenario, not this one. Okay, tell them in room 3 quickly finish so next patient goes. No, I know, but they should finish it. So go to next one.
No. See, I told you that.
Yeah, this Lima has been a struggle right through.
Now what you do is advance wire a little more.
It does not go.
The anti-grade. No, wire went. I put the wire under here. Little
not
more
in
body
the-
of the wire. Yeah, good.
Go up here.
Yeah.
Let's try to dilate. Then advance.
Okay, go up. 6, 8, 10, 12, 14, 16. Good. Now,
Okay.
Hmm?
Dilate. Let me dilate and hold.
okay, go up. Now it's coming out. No, everything coming out.
Okay.
You're down. Right? Hmm?
So give some anti-grade dye. Maybe we have created a channel.
Something is there, a faint outline,
Very little.
but very hard to.
Say, yeah.
Want to try anti-grade picture? Now?
Yep.
Take out everything, right?
Can try this wire in more movement?
It doesn't happen.
No.
I think it's outside also. Retrograde dye. This guide is
Yeah, I had observed that it's been a
have to
struggle,
change. I
right?
think anti-grade is making some good progress, no?
Hmm?
Give retrograde.
Okay, take a cine. Yeah, it looks like wire in a different position. I think it's a reasonable now to stop here. Samin, you agree with that now?
Did you ask Anu or me?
You. No, I think because we have tried enough.
It's strange that you ask. Ricardo sitting next to me, I had gestured to him just about 2 minutes ago that I think you may be making this decision. It's always tricky and hard to give up, but I think that does appear to be the right decision.
Okay.
Anu, is that your thought too? Of course,
Yeah,
now I see you pulled the wires. Very important to conclude the case by taking final pictures.
Yes.
And everything looks all right. And
Let me take one cranial decision to bring back or no.
right. I'm fairly certain that the decision would be to bring him back. And of course, in a subsequent presentation, we'll provide you a follow-up on how this patient did.
Did I integrate anything?
To your credit, I can tell
Integrate.
you that you gave it absolutely the best shot with just about every wire and every support catheter available to us.
Yeah, no, nothing with the integrate. Okay. All right. So let me just conclude our this long presentation. Hopefully, a lot of educational points. May not be a successful case, but no complication, and we still continue to work on these challenging cases. So basically, our take-home message was optimal management of diabetic CAD, and of course the randomized clinical trial from European Society of Cardiology. The pooled analysis of more than 5,000 diabetic patients with BMS or first generation DES showed that cabbage is superior to PCI or optimal medical therapy in terms of reduction of primary endpoint of death, MI, stroke, and higher TVR. The patients, and of course, means all of them actually should be that the primary endpoint of death, MI, and stroke, as well as the TVR. So it should be lower TVR. Data with newer DES versus cabbage showed that mortality is similar between two groups, but higher stroke rate with cabbage and higher MI and TVR with the PCI, and that is the key. So kind of slightly higher MI in the with the newer generation DES. The first randomized trial of OCT guided PCI in ACS patients showed higher FFR post PCI and better stent optimization in OCT group, but no difference in clinical outcomes at 6 months. DES has similar long-term outcomes to BMS except for lower TLR and slightly reduced stent thrombosis with a p-value of 0.052. Trial comparing ticagrelor versus prasugrel in MI showed similar efficacy of MACE and bleeding in these the patients. So quickly, our 3 questions: that following statement is true regarding the published data about optimal management of CAD in diabetic patients. 1. PCI with first generation DES has higher mortality versus cabbage, means what is the wrong statement? Second, PCI with first generation DES has higher MACE versus cabbage, PCI has higher TVR versus cabbage, PCI has lower stroke rate versus cabbage, or PCI was second generation DES has higher mortality versus cabbage. So clearly 1 is the wrong answer. Second, Tuxedo India trial showed the following except everolimus eluting stent has lower TVF versus paclitaxel or has similar stent thrombosis as paclitaxel, lower MI versus paclitaxel stent, or is similar mortality versus paclitaxel, and insulin dependent diabetes has higher MACE versus non-insulin dependent irrespective of the stent type. The third and last question is a doctor's study evaluating the impact of OCT guided PCI revealed the following except that higher post PCI FFR in OCT versus angio guided group, higher percent of patients achieving FFR of more than 0.9 in OCT versus angio group, higher post PCI optimization in OCT group versus angio, lower 6-month MACE rates in OCT group versus angio group, and lastly better stent expansion in OCT group versus angio group. So these are the questions. We always put our answers on the website, and we invite everyone to visit, and in 2 months later we should give you follow up on this particular case. right? And you feel like you'll bring the patient.
I'll ask Anu about her final comments, but I want to make a very important observation after watching you very closely over the last almost 90 minutes. See, many CTOs will go through the course which you have observed here, and I think to me the best message here was to maintain your concentration and discipline so that you don't have a complication that preserves the chances of bringing the patient back and ending the procedure safely without a complication. I think was the best take home message for me. Anu, what are your thoughts here as we conclude this case?
Yeah, I mean, to begin with was extremely challenging CTO, I can tell you, since was almost close to 90 or 100 millimeter CTO, where we knew ostium up to the distal RCA to the crux, and doing it retrograde. I think the biggest issue was the septal that we had to was the third septal, and that too it was angulated.
It was very democratic. Let's leave it that.
Let's leave that. And there what happens is, because of that we were not able to get the corsair further down, and without the support of the corsair, even if our wire was there in the mid to proximal RCA, further negotiating the wire was still very hard. So going back to the point, should we bring this patient back? I think having that we tried antegrade, retrograde and struggled so much, I would not be very optimistic in bringing this patient back. We will
and if you brought the patient back, chances are you would have an antegrade channel, no?
I think what we have created antegrade channel is more of a subintimal track that we have created. But since he is young, we will see how he does. If he continues to have symptoms, before sending him for single vessel bypass, we will always try, but definitely will not do retrograde again, having faced this challenge.
Right. Yeah. Samin, your thoughts, same strategy?
I mean, our only question is, if we decide for cabbage, I think this case will be, it's just to see some rare chance that we see antegrade channels of what we have created. So we bring him back in about 2-3 months,
and then
that time do an angiogram and do two things. If you don't see a favorable for the coronary anatomy for CTO, do FFR of both LAD and SIRC. So once you are sending for surgery, I think cabbage, it will be reasonable to really evaluate that should they put a bypass into those two other vessels also.
No, other thing is, before we bring him, maybe we will get a CT angio and see how the RCA
or CT angio, that's perfectly
fine. We'll do that before we bring for cath, and then we'll do the rest. But we will definitely give the follow-up on this patient.
All excellent discussions, including, I was about to say what you just mentioned, we'll provide a follow-up. Thank you all for patiently staying with us during this long transmission. We'll see you October 18th for the next live webcast.